Good morning or good afternoon, everyone, depending on where you are joining us from today. Welcome to RadNet's first Men's Health Coast to Coast webinar. I'm Michael Coords, Medical Director of Cardiovascular Imaging, RadNet West, and I'll be co-moderating today's discussion along with Stephanie Landon, our Director of Communications and Public Relations. I am joined today by my two colleagues, Dr. Evan Kaminer and Randall Stenoien. But before I introduce my colleagues, I wanted to add an important disclaimer. While we are physicians, today we are not your physicians. This is general medical information meant to facilitate discussion with your own physicians and to encourage your own research into these topics. So, my two colleagues today that I would like to introduce. First is Dr. Kaminer. He is our medical director of New York Hudson Valley region. He has been a radiologist for 30 years, 28 of those with RadNet as medical director of Lenox Hill Radiology North. Dr. Kaminer specializes in advanced chest and abdominal imaging. Our second presenter today, along with myself, is medical director for Texas, Dr. Stenoien, who's been a radiologist for 38 years, specializing in body and prostate imaging. He has held multiple leadership positions, both clinical and within the Texas non-medical community. It is really an honor today to be presenting these important topics along with my two colleagues during Men's Health Month. These gentlemen are not only experts in their field, but really are very passionate about preventative screening. So for today's agenda, this is going to be about 1 hour long webinar. If you are not muted, I'm going to call you out, Dr. Stenoien. A little bit of background interference there. Please make sure you're muted so we don't get any echo. Today's webinar is going to be about 1 hour, and we're going to focus on three important topics. Those are lung cancer screening, prostate cancer screening, and coronary artery disease. Three very important topics for men's health. For today's agenda, we're going to have a short presentation on these important topics and then have a panel discussion talking amongst ourselves, engaging with you, the attendees, answering your important questions so that you can have these discussions with your doctor after today's webinar. So first up, Dr. Kaminer, he's going to be presenting CT lung cancer screening. Dr. Kaminer, the floor is yours.
Thank you, Dr. Coords. I'll take my second slide, actually. You can skip the first one. Okay. So I'm going to talk about lung cancer screening. When we talk about lung cancer, most people know that smoking causes lung cancer. And for the most part, lung cancer screening is geared towards smokers. The reason why we screen is because lung cancer is the largest cause of death in both men and women in the United States. And the reason why it's so deadly is because typically by the time you identify symptoms and go to the doctor, it's already spread to the point where you have limited treatment options. So the goal is to find it earlier when we have more treatment options. You'll see these two pictures here which I took from the SaveByTheScan.org website. It's just to show you that this is a national push from government, insurance companies, Medicare, to get patients who are at risk screened for lung cancer. Next slide. So this is from the American Cancer Society, and this chart shows you the incidence of various cancers in the U.S. And you'll notice that for men and for women, lung cancer is the second most common cancer, but it's the most common cause of death among cancers. So there's a flip between number one and number two for both men and for women. And we want to try and change that and get lung cancer back down to where it should be as far as its risk for death. The reason why breast cancer and prostate cancer are less likely to kill you than lung cancer is because we screen for them and we can find them earlier. And now we have the ability to do that for lung cancer as well. I'll take the next slide. Again, a graph from the American Cancer Society. And this graph shows several different cancers over time. And you see at the bottom of the axis, it starts in 1930, way back when, and it ends about in 2023, which is obviously very recent. You could see that lung cancer, the deaths from lung cancer rapidly increased from 1930 to about 1993. Okay. The reason why is since from 1930s on, there was a big increase in smoking. And just thinking about the World War II movies, everyone was smoking in World War II. But it was in 1964, 1965 that we made the correlation between lung cancer and smoking. And 1965 is when the Surgeon General warning showed up in cigarette packs. So the problem is that it takes 30 years, roughly, for a cancer to develop from a smoker. So we did not see the benefit of that smoking decrease until the mid 90s because it took 30 years for those people who were smoking in the 60s and 50s to develop their cancer. You'll see that prostate cancer peaked around 1995, and that's because we were able to start doing PSA screening so we can find them earlier. And colorectals peaked around 1985, right when we started doing colonoscopy. So there's clearly a benefit to screening. It's just that it's only recent that we've had a screening test for lung cancer, and we want to drive that death rate from lung cancer way down. Next slide. So who should get screened? Well, these guidelines come from the American Cancer Society, and they're followed by Medicare, followed by the insurance companies as well. So we screen people 50 to 80 years old who had a 20 pack year smoking history. Pack years is a way to determine how much you smoke. So if you smoke 1 pack a day for 20 years, that's 20 pack years. If you have 2 packs a day for 20 years, that's 40 pack years. There are lots of calculators online that you can Google and find to calculate your pack year, or maybe it's not you that's a smoker. Maybe it's your spouse, maybe it's your parents. So I know I'm talking to men, but it's not just men, it's women, parents, everybody. So find out what your pack year smoking is and see whether you're a candidate. You have to either be a current smoker or quit within the past 15 years. The reason why we cut off at 15 years is because after 15 years, your risk of developing a cancer goes way down, not too much above the baseline of a non-smoker. So they cut it off at 15 years. And this is a yearly scan, just like a mammogram. When we get mammograms every year for people who are at risk for lung cancer, we screen every year as well. It requires a prescription from your doctor because we do use radiation, so that requires a prescription, and it's covered by Medicare and all insurance carriers. Next slide. So the picture on the right is a picture of a lung cancer in someone's chest. And the goal is to find these lung cancers small so that we can just do what we call a wedge resection. Think of a wedge resection as the equivalent of a lumpectomy for a breast. We want to just cut out that tumor. It's a relatively simple procedure to do it compared to what you would have if you had a more aggressive lung cancer. And it often requires no radiation, no chemotherapy after we do a wedge resection. So the goal is to find them early so they're easily treated. If we scan every patient that's at risk for lung cancer, we can save 30,000 lives per year. Next slide. Okay, so the test is very easy. I mean, women complain about mammograms hurting. Well, this test, nothing touches you. You don't get an IV. The scanner doesn't touch you. You basically come in, you lie down on the scanner, you hold your breath for about 10 seconds, and you're done. That's it. Your head never goes into the tube, so there's no claustrophobia. The whole from arrival to leaving the facility is usually about 30 minutes. A very easy test for people to do. Next slide. So what are the results you could expect? Well, it turns out only about 25% of people that have this test have no lung nodules at all. Most people, about 2/3 of people who get a CT chest or even this screening test, have small lung nodules which are benign. They're very common in normal people. So my job as the radiologist is to figure out which ones are more concerning than the baseline normal ones that we see. So if you have no lung nodules or you have all benign looking nodules, we'll see you next year. That's it, you're done. Sometimes the nodules might grow a little bit or look a little bit more suspicious. Then we might put you into the probably benign category where you would then come back in 6 months. We take a look at that nodule. If it's okay, you come back in another 6 months. If it's okay, you come back yearly after that. Only about 5%, a very small percentage of the people that have this test actually have a suspicious lung nodule. And if you have a lung nodule, then you'll go on to additional testing, like a PET scan, which will help determine if this could be a cancer or something benign, or you might go on to biopsy or other things. But it's only a relatively small percentage of people that get scanned that actually end up going on to additional testing. Next slide. There are some things that you should know that can be frustrating about this test. We talked about the fact that most people have benign nodules, so that can be a little concerning. If you're already on edge about maybe have a lung cancer, you find that you have a benign nodule, that still could be a little concerning for you. There is a push in medicine now to not treat every cancer. We want to treat the cancers that would affect somebody's life, and not the cancers that would not affect your life. Unfortunately, we don't have a good sense yet exactly which cancers will go on to be more aggressive. So typically we treat all the cancers at this point. But you should know that it could be that the finding we have might not have had to been treated. But that's the discussion you will have with your doctors if it ever crosses that path. There is radiation involved in this test, and just like any radiation, there's always a risk of bad outcomes from the radiation. The best I could say about that is that there are a lot of smart people that designed this test, statisticians, and they did the math and they found out that your risk of developing a cancer from the radiation for this test is far less than your risk of developing cancer from smoking. So you can rest assured that if you that you are better off having this test with the radiation and all than not having the test if you meet the criteria for scanning. And then there's also incidental findings, which is very frustrating for anybody who gets radiology imaging, whether it be this test or any other test. Typically, we're looking for one thing, we find something else unrelated, which can then lead to additional testing, which can be very frustrating until it all gets worked out. So it's kind of baked into all radiology procedures, but when you're going for a screening test, then to find out you have to go for another test because we found something, it can be a little frustrating as well. Next slide. 1 in 3 cancer deaths are caused by smoking, and it's not just lung cancer. There are about 20 cancers on this graphic that I show you here that can be attributed to smoking. The smoking gets inhaled to your lungs, it causes lung cancer. It passes through your mouth, it can cause oral cancer. It gets absorbed by your bloodstream, it can then cause stomach cancer, kidney cancer, lots of other cancers. But the number one thing that you can do to reduce your risk for these cancers is to quit smoking. Your risks drop for cancer relatively quickly once you stop smoking. There are lots of resources to help you quit smoking. You can talk to your doctor. There are government resources to help you. Once you're ready to quit, it's easy to find resources to help you achieve that goal. Next slide. There are many people that don't meet criteria for screening but want to be screened. They may be quit smoking 20 years ago instead of 15 years ago, but they still want to be screened. They may have lived in a household with somebody who was a big smoker and have secondhand smoke. They're not eligible for screening. So we have a self-pay pathway that doesn't go through insurance to allow people who need to be screened get screened. Firefighters, there's a big push in several states to get screening for firefighters because firefighters have an increased risk of lung cancer. And there's also government funding for veterans who were part of burn pits and other military issues where they might have exposure. So there are occupational exposures that can increase your risk for lung cancer. And if you want to get screened, we do have a pathway that can help you get screened. However, you do need a prescription from your doctor, so you'll need to talk to your doctor about that. And I think this is my last slide.
That is your last slide. Thank you very much,
Okay,
Dr.
good. Thank
Kaminer.
you.
We'll move on, Dr. Stenoien, in just one moment. But what you just mentioned on this slide here was really important because people really think about only smokers when it comes to lung cancer screening. And you have all this other group of people who might have environmental risks other than smoking themselves. So I'm sure we'll touch on that again during the Q&A, but I think that was really important. And one thing which I will bring up to the team and everyone attending, something you said right before we started really shows your passion for this. Right before we went live, you had said, if this saves just one life, it makes it worth it. So you're definitely, you're just so passionate about this, and we're glad to have you on there today. So thank you so much.
Thank you. I appreciate that. I do.
Next up, we have Dr. Stenoien presenting prostate cancer screening. Dr. Stenoien, the floor is yours.
Thank you, Dr. Coords. Next slide, please. So before I talk about prostate screening, I want to talk a little bit about prostate versus breast cancer. They each have an incidence of about 300,000 new cases per year. They each have approximately 30,000 deaths. We're all aware of the pervasive use of screening mammography, all not necessarily just United States, but worldwide. And it's been in place for a long time. So it's remarkable that these two diseases, which have similar risk profiles and similar death profiles, have a completely different approach. One incredibly detailed and regimented screening, and the other really no screening programs whatsoever up until now. Next slide. This is an important slide because it shows the incidence of prostate cancer by age group. And as you can see, prostate cancer is, it's an age of the older males. It starts off probably significantly above the age of 45, and it peaks in the age groups of 75 to 85. When you talk about screening programs, you want to impact the population and by improving survival, by improving quality of life. And so we have to determine what is the sweet spot in terms of the patient population we're most likely to aid. And I think the sweet spot is pretty much between the years of 45 and 70. Patients with a long life expectancy, early diagnosis, impacting their survival, impacting the quality of life. Next slide. Mean age of diagnosis for prostate cancer is 67. The mean age for breast cancer, anywhere between 62 and 64. We know that breast cancer patients do have a higher incidence of aggressive cancers in younger patients, and that's why we start screening at an earlier age. A couple of high-risk populations we need to be aware of. Black males have twice the incidence of prostate cancer. They tend to have more aggressive clinical courses. Also, people with a strong family history, if your father or your brother had prostate cancer, you have twice the risk of having prostate cancer. And just kind of a miscellaneous item here, in order to close the loop when we're doing screening, we not only have to identify these high-risk patients with screening, we also have to be able to give them a biopsy accurately in a timely fashion. I'll talk a little bit about that as we get to the end of the presentation. Next slide. So I feel like we're still in the wilderness when it comes to prostate imaging. If you look at our institutional guidance, we're not really getting any advice on how to attack this challenge, how to attack this issue. National Cancer Institute, there is no standard or routine screening test for prostate cancer. They recognize the utility of a digital rectal exam. They recognize the utility of a PSA test or MR imaging, but really in the context of just natural diagnosis and treatment, not screening. Next slide. The U.S. Preventive Services Task Force made recommendations in 2016 regarding the diagnosis of prostate cancer. And the recommendations were fairly scant. They said, you know, we can consider the use of PSA blood tests in individuals between the age of 55 and 69 on an individual basis. But they recommended against performing this PSA test in patients older than the age of 70. Admittedly, we were diagnosing too many prostate cancers in elderly patients. And from a population epidemiological perspective, we probably weren't impacting patient care as much as we thought. But at the same time, we have to recognize that these recommendations were made in a vacuum of data. It was only at about that time that prostate MR imaging really began to explode. And so for the last 10 years, there's been no updates on how to manage this disease, while at the same time, there's been incredible advances in our ability to image these patients effectively and quickly. So next slide. So I have to thank Evan here for sharing this information, because there was a very recent and timely publication that came out of Europe. And this publication basically addresses the practicality of prostate screening. They looked at all the scientific data, and there's a tremendous amount of data that's come out over the last 10 years, and they made these recommendations. And I have to say I'm impressed, because they really mirror the prostate screening program that's been developed here at RadNet by Dr. Princenthal. It's very supportive and encouraging data that's coming out. This is not an official consensus, but they came to the following conclusions. First, we need to image patients who have a life expectancy of at least 10 years. Our target population, age 50 to 70, hits that sweet spot that I talked about a little while ago. We should start earlier in patients who are high risk, Black males, patients with a strong family history. They recommend the PSA, although there was no consensus on the cutoff value. And most importantly, they address issues of quality standards for imaging our patients, quality standards for interpreting the studies, and quality standards for reporting. This is not an official consensus, but I think we're getting really close, and hopefully our guidance from our leading institutions is going to be changing in the near future. This is about as good as we can get right now. Next slide. So a few concepts or a few things to understand about MRI. First of all, there is no radiation involved. We use a scanner with radio waves within a magnetic field. We know based upon the scientific research that it's very effective at identifying particularly aggressive and clinically significant cancers. Oftentimes it misses the cancers which are less aggressive. It's a non-invasive test. At RadNet, it takes 10 minutes to complete the study. There's no bowel prep required. And just to contrast it with a regular diagnostic study, with a diagnostic study, we're getting the same anatomical images, but we're also adding IV contrast, and we're requiring a cleansing bowel prep before we do the study. Next slide. Cost is $275. Our minimum age of imaging is 45. We do not require a PSA, but we recommend it, encourage it. Before you're screened with MRI, we're going to make sure that it's safe. There are some patients who have cardiac pacemakers, defibrillators, implanted medical devices, or maybe metallic foreign bodies that probably cannot safely undergo an MRI. We're going to make sure that it's safe before we put it in there. We do exclude people who have had a previous biopsy, people who have a diagnosis of prostate cancer, or people that have a very high PSA result greater than 10. Those patients should probably get a formal diagnostic exam. Next slide. Artificial intelligence. It seems to be a buzzword, but honestly, it's really changed the game when it comes to MR prostate imaging. It's affected our ability to do a better job in two ways. First of all, at the machine level, GE, Siemens, different vendors have used artificial intelligence and image enhancement to improve the quality of imaging and improve the rapidity with which these images can be obtained in order to make 1.5 Tesla imaging comparable to 3 Tesla. 3 Tesla was the standard 10 years ago. With the new artificial intelligent image enhancement, we can get the same quality images in the same amount of time on a 1.5 Tesla unit. And these MRI devices are much more widely available. So it makes it easier for all patients to get good quality images. The second component with artificial intelligence is the software processing of these images. There are different vendors that have different products. Here at RadNet, we use a deep health product called Sage Prostate, which enables us to process these images, segment the prostate, identify suspicious lesions, and actually export the data so that the urologist is able to do an effective and accurate biopsy. It's an extra pair of eyes, but it's more than that. Next slide. Here's a picture of a prostate. This is the anatomical piece of the puzzle, the T2-weighted image. We can see the prostate in the middle with some areas of decreased intensity there. Next slide, please. The second acquisition is what's called a diffusion image, and diffusion images are very sensitive at detecting cancer. Next slide. Through the use of our particular product, Sage Prostate, we're able to fuse these images, and the software algorithm will actually identify areas of restricted diffusion within the background anatomy. You can see the purple areas there. The software has targeted. The radiologist reviews these images and decide what they feel is clinically significant or not. Next slide. And to complete the loop, the software will generate a three-dimensional rendition of the prostate. The green and the yellow targets there are actually the targeted cancers that we saw on the scanner. And this information can be exported to the urologist who can use an ultrasound device in his office and do the biopsy in a very cost-effective and timely and, most importantly, accurate method. So we're closing the loop here. So just to summarize, in order to have a good screening exam, and we're waiting for a consensus, but we think we're already there, you need something that's cost-effective. You need to choose the correct population that's going to benefit the most. You want to make sure you have the best quality images. You want to have the appropriate software to process the images, and you want to follow standards and be able to export the data so that we can get a biopsy. So I'll stop with that. Thanks for your attention.
Thank you, Dr. Stenoien. Those images are really incredible. I haven't seen prostate MRI software being used recently. I don't think the last time I personally looked at a prostate MRI was during residency, and we didn't have any of this artificial intelligence or this analysis. So that's really incredible. Thank you. Now I'll be discussing coronary artery disease and why it's so important to catch it early. And, about this entire webinar, men can sometimes be somewhat reluctant for preventative screening, preventative maintenance of their own health. And particularly when it comes to coronary artery disease, you know, when you look at men outside of their own personal health, I have friends and family members who take a look at their car, for example. They'll change the oil every 5,000 miles. Oil today sometimes can go 10, 15, 20,000 miles potentially. But maintenance on schedule, 5,000 miles, they change it preventatively. They're not waiting for a warning sign to go on your warning light, but absolutely, I need to change it. I even have family members who have these newer transmissions that are lifetime fill transmissions. You don't need to touch them. They don't even have a dipstick anymore. Um, they'll go out of their way to find a way to drain that transmission fluid oil, drop the pan, install a whole new pan that has a drain plug just so they can go above and beyond their manufacturer's recommendations because they don't want there to be an issue. They're not waiting for a warning light to go on. They're not waiting for someone to say, oh, you need to do this today and then put it off. They're being proactive. But when it comes to their own health, oftentimes men are waiting for that warning light to go on. Maybe they think that warning light's going to get brighter or another warning light's going to go on before they do something. So it's just very interesting that men can be reluctant. And that's why we're doing this today is to help educate, to know that you catch things early, you can change the outcome, and it's very, very important for your health. So for coronary artery disease, it is the leading cause of death. It does not have to be. 1 out of 5 people in the US are going to die of heart disease. It's been like that for many, many years. It happens over time, though. It's not something that happens, in the last week, last month. This happens over a period of years, oftentimes decades, with multiple causes. But if you can catch it early, you can stop it in its tracks. So there are 4 things that I really want to hammer home today. And if you take away nothing else, I think this one slide is maybe the most important. Some people are very reluctant to take medication. I get it. You don't want to take a medication if you don't have to, but not every patient needs medication. You don't know whether or not you're the type of patient who needs it or not until you actually take a look. Another very important part is for the first time in my career and really in the history, we can really stop the progression of coronary artery disease. It is not inevitable. We had some conversations earlier and some other educational things we had done, and people said, coronary artery disease, it's just part of getting old. That's like just saying arthritis is just part of getting old and back pain. Yes, it's more common, but it's still a pathological process. It is still something that can cause disability, and in the case of coronary artery disease, death. But you can catch it early and you can stop it. And in some cases, you can even reverse it. The third important part is historically, we didn't have a good way to image coronary artery disease. We use these risk calculators. Going back to my car analogy, it'd be like saying that your warning light went on and you said, well, based on the make, model, the number of years you have on your car, and the color of your car, it's going to be your water pump. Why not just lift open the hood and take a look? Imagine if you went to a mechanic and they just said, based on how many miles you have on your car, statistically, it's your water pump, so we're just going to charge you that to replace it. It would make no sense. But that's what these risk calculators sometimes do. They are good for the masses, yes, and it can help change the recommendations about when to take a look. But you need to take a look, and if you're not, you're really just guessing. And the fourth important part is there are non-invasive ways to look for coronary artery disease. So talking a little bit about why this is so important. Most people will assume that if your warning light has not gone on, you have not had symptoms, that you must be fine. But the truth of the matter is, over 50% of patients do not have symptoms prior to having a heart attack. That warning light didn't go on. The warning light went on as you're having a heart attack. Because what happens is it's not about how narrow your arteries are. How much of a blockage do you have? It's more about how much plaque is there that can rupture. So if you're just going based on risk calculators and symptoms, it's going to fail a lot of patients. Oftentimes, there are no symptoms leading up to it. So it's not to say that blood tests aren't important. They are. It's not to say that risk factors aren't important. They are. Um, but how do you use that in part of your overall health maintenance, preventative screening? Oftentimes, how they're going to be used in the real world is if you were at a higher risk, you would be screened earlier. You might have a recommendation for certain screening intervals for most people. But if you are a higher risk based on these calculators, maybe you should be screened a little bit early, making sure that for you, we catch it early enough to prevent a major cardiac event, a heart attack. So, when to start screening? It's important to note that there are no general recommendations for everyone that everyone can agree upon. There are expert statements. There are groups who have come together to give some general considerations and recommendations, but there is nothing set in stone that we might have, say, for women's imaging and breast cancer. We don't yet have that for coronary artery disease. I'm hoping that eventually we will, but right now, some general recommendations that will help you have these conversations with your doctor would be for men starting around the age of 40 and women starting around the ages of 45 to 50. There are multiple papers discussing this and about why those ages. But if I go look at these different risk factors on the screen here, very strong family history, elevated lipoprotein A, which is a type of blood test, which I would encourage you to talk to your doctors about if you've never been tested for, as well as other risk factors that might shift the screening a little bit earlier. If you have a very strong family history, certain groups like South Asian descent, we see the coronary artery disease come on much earlier in life. So instead of starting at age 40, maybe you start at age 35, 36. You need to talk to your doctor about what is right for you. So the two primary ways to look for coronary artery disease, actually taking a look, would be a non-contrast calcium score and a coronary CTA. A calcium score, it's a very quick exam, does not require any contrast, and it looks for the calcified plaque that's in your coronary arteries. That can help guide medical management. So if your doctor sees that calcified plaque, they might recommend a medication, or you can be more aggressive with your lifestyle modifications. The best way to look at coronary arteries, or I should say the most complete way, would be a coronary CTA. This is not the screening recommendation for everyone. In fact, the first screening choice for most patients, based on the data we have available today, would be a calcium score. However, for certain higher risk populations, a coronary CTA really is the best test for screening. That is because not only do you see that calcified plaque, you could also see the higher risk non-calcified plaque that's more likely to rupture and cause a heart attack. So a calcium score, very fast. It's only a few second scan, does not require any contrast. That means no IV needed. You do require a prescription from your doctor. Oftentimes it is not covered by insurance. Believe it or not, leading cause of death, we still don't have a lot of insurances that cover preventative screening for coronary artery disease. Our RadNet, we offer a very reasonable cash pricing to help increase access to care so that you can use this data to help guide your own management. No prep needed. You don't need to be fasting. You can keep with your normal medications that you take that day and get a very quick scan. For a coronary CTA, for the more thorough evaluation for patients who might be at higher risk for the non-calcified plaque, it does require a little bit more preparation. The actual scan acquisition is only a few seconds longer, but the whole time that you're in the office might be about an hour, hour and a half, because it does require placing an IV, giving some contrast, and at times having some medication to potentially lower your heart rate if needed. Because we are imaging a moving structure. If it's moving too quickly, your heart, it can be blurry. You want to make sure you get very accurate results. But I'll reemphasize the point that this is not currently the guidelines for screening for all, but for certain higher risk patients that you can see on the bottom right of the slide here, that is certainly something to talk to your doctor about as an option. What we also have today, and I was very impressed when Dr. Stenoien was talking about all the AI-powered analysis for prostate. We also have AI-powered analysis for coronary artery disease when it comes to plaque analysis. for the first time in the history of imaging coronary artery disease, we can actually quantify all the amount of plaque that is in your coronary arteries and personalize care for you. So if you have some patient who has calcified, more stable plaque in a small amount of it, compared to someone who has a lot more plaque burden, you are going to want to be more aggressive who has more plaque. And you can monitor it over time. So let's say you want to try conservative measures, saying, you know what, medication, I don't want to start with that. I want to try to change my lifestyle, eat healthier, exercise. And you had a coronary CTA with plaque analysis, and you were very aggressive with your lifestyle modifications. You come back in a few years and you image again. Maybe you stopped it in its tracks. Maybe what you did was enough and you do not need medication. But what if it was getting worse? What if all of a sudden your plaque got significantly worse over the last few years? Well, we know for you, while you're not having symptoms yet, the modifications that you made was not enough, and you were on a bad course. So you can use this to tailor your treatment options. So conclude with this last slide. If you want to go into more detail, today was a very superficial overview. We have done discussions on this before related to actually seeing a patient having a coronary artery calcium score to see what the process is like. So you know exactly what you're going to be expecting that day. We also have done a video on coronary CTA with plaque analysis. I would encourage the attendees to take a look so you can educate yourself with a little bit more. What's really important, though, is that you take a look so that you can choose a new path in life. If you could see the future, you could see that cliff coming up ahead. If you did not change your lifestyle, your management, and you knew something bad was going to happen, I think most people would exit that road pretty quickly and say, you know what, I'm not going to drive off that cliff. So thank you all. And now we are going to move on to the Q&A discussion with my two colleagues. Thank you all. All right, Stephanie, we have some questions from the attendees.
We do, and thank you all so much for that insightful presentation. So yeah, we have some questions we can get to start off the conversation. The first question is, what is the difference between a CT lung screening and a regular CT chest?
There's not much difference. The biggest difference is the dose. When we do a CT lung screening, we try to keep the dose as minimal as we can to get the answer that we need to. But for a CT chest, because there's so many other things we're looking for, we have to increase the dose. The dose for CT chest is about 6 times that of a of a low dose CT lung screening. So we would rather you not get a regular CT chest if you're just screening for lung nodules, just because it's really just a dose. And we also, right now, the other two presenters talked about the AIs that they have. I also have AI that I work with that helps me find the lung nodules, which can be a needle in a haystack kind of process. So right now we only use that AI for the low-dose CT lung screenings, but we're going to change that within the month. We're probably going to use the AI for everything. So that change is going to go away. But the biggest difference is the dose.
Okay.
That's really impressive. And Dr. Kaminer, with the AI that you're using, is this the AI that can, I guess, track small changes over time with the nodules and see if something's growing?
Well, it helps us find the nodules, and
Hmm.
because it's like a needle in a haystack. You're looking at these lungs, you have to find
Hmm.
these. Some nodules are very small, so the big ones are easy to find. The smaller ones are a little harder to find. Um, but it will not. Then when you come back the next year, it will tell us here's this nodule, and the nodule has changed by this much, and we can
Wow.
track it over time.
Wow.
And then, there's different standards between Europe and the U.S. The U.S. doesn't use a change of volume as part of its screening
Hmm.
program, but in Europe they do. So, but it will tell us if a nodule is growing and when to be concerned.
Interesting. Very interesting. One other quick question for Dr. Kaminer, and a question that commonly comes up in my family members. Also, when it comes to symptoms, right? People think that you're going to be coughing, you're going to have shortness of breath, and all this before having a potential, lung cancer. Is this commonly how patients present?
Well, the signs of lung cancer could be just a cough. It could
Hmm.
just be shortness of breath. But as you know, those things are pretty common. So the question is, when do you want to go on to more testing? The cough that doesn't go away after a couple of months, maybe you want to get tested. Things like, coughing up blood can be a more worrisome sign for people. People are used to coughing, but they're not used to coughing up blood. So some things are a little bit more obvious, but some of the symptoms for lung cancer can be so common that that's why we find them so late because most people just say, "Oh, I got a cough." It's lasted a couple weeks, but I cough all the time, no big deal. But they don't know that there's something there.
Great.
I
Thank
have a question actually about something you mentioned, family history as a risk factor, which I find sort of surprising because we think of lung cancer as being, from smoking or environmental. So how
Right.
much of a risk factor is that? And like, should you be worried, if say, your grandfather died of lung cancer, but he also smoked, I
Right.
mean,
Right.
where is that risk factor?
Well, lung cancer can occur in people that never smoke. Think of a Christopher
Yeah.
Reeve. He's the most famous person that we know that occurred to. If you're in that category where you had somebody, a family member who developed lung cancer and they never smoked, then there's likely a genetic predisposition. But if someone smoked and developed lung cancer, it's more likely that the smoking was the cause of it. But we really don't know, and it's really almost impossible to slice it so perfectly. Let's say when there's not a lot of genetic testing that goes on for lung cancer. So, most of it is you smoke, you develop lung cancer. Let's treat it. Right.
Right, right.
Dr. Kaminer, one of the questions I see from one of the attendees, if I'm going to summarize here briefly, is right now, a lot of the recommendations for screening has to do with smoking in certain pack years and all that. Do you see those recommendations potentially being expanded to people who have been smoking for a shorter period of time, cannabis users, or other risk groups?
Well, we did already reduce the age in which we start screening. It was higher than it is now, so that's already happened.
Hmm.
It is fluid. It does change over time, but remember, we do have this risk of radiation. So we always have to counterbalance. If there was no radiation risk, we would say, okay, let's just screen everybody. But we don't want to do harm to people. So that's why we do have these criteria. I don't expect them to change much. Now, vaping is a different
Well,
story because we don't really know whether vaping causes cancer for sure. Because remember, I told you there's that 30-year lag period between when you
Yeah,
started smoking or you stopped smoking
true.
and developed the cancer. We haven't reached that point with vaping. We're about 20 years into vaping at this point. There are some early signs that have physicians concerned that it's going to be just as dangerous as smoking is. Uh, but we really don't know just yet. We still have another 10 years or so before we're going to have the answer to that question.
Got
But I would not vape. Let's just be clear.
it.
I would not vape because there's other stuff that goes into vaping too. You're inhaling
True.
all kinds of chemicals. There was a time about 10 years ago when before vaping was so legal, let's say, where people were getting these drugs off the street and they were having
Oh,
toxins causing all kinds of problems with the lungs. Those that seems to have settled down now that you can get them through more legal channels. But vaping is a bad habit. I would not vape.
would you say it's safe to say inhaling anything other than oxygen and air into your lungs might be a higher risk?
It depends on how much you inhale, right? I mean, if you're a construction worker dealing with
Right.
toxins all day long, then you might want to wear a mask. But if you're
Mm,
if you're if you're just doing something in your basement for the first time, you never do it. It's a cumulative thing.
got it.
And
Good
and there
information.
are other diseases besides cancer that can be a cause of inhaling things. You can get pulmonary fibrosis, other inhalational diseases that have nothing to do with cancer. So it's not just the cancer we're worried about.
Mm, interesting.
well, while we're on the topic of lung, I wanted to quickly ask you a question I have here is that is a CT lung scan, is it claustrophobic? Like, are you in the tube or?
No, you're only going the tube up to your neck. That's it. So your head is always out. You can always see out. So we image from about here. We can see it actually here down. So your head never goes into the tube. So people don't have claustrophobia from this. Believe me, I deal with claustrophobia all day long. I'm a radiologist. I have to manage it. This test does not cause claustrophobia.
Okay. And people who quit smoking years ago, what would your advice to them be?
Well, we know that after about 15 to 20 years of non-smoking, your risk for cancer drops down almost to baseline. Never quite to baseline, but almost to baseline.
Mhm.
So if you quit smoking years ago, if you're less than 15 years, you should be getting annual low-dose CT lung screening. If you're more than 15 years, you're past that worrisome threshold. If you look, there are people, everyone's different. Some people are very blasé about it, some people are very concerned about it. If you're one of those people that I'm sorry, the doctors tell me 15 years the cutoff, but I'm still nervous. There is that other pathway that we have where you could have a cash payment for to have the same exact test, but for a cash payment because insurance won't pay for it after 15 years.
Right. Okay. And one last question for you. Can the imaging detect other lung diseases aside from cancer?
Absolutely, yes. The test is a full CT, so we often see people with other diseases, those incidental findings. Sometimes we see people with fibrosis in their lungs from various reasons. It's a different topic to talk about. We'll see, people. I often see people with pneumonia. I mean, to come in for a lung screening, and we turned out they have pneumonia. They had no idea. They had that cough that maybe they just said, "Hey, I cough," but it turns out they had pneumonia.
Mm.
So yeah, we find lots of other things on the low-dose CT lung screening. We don't limit what we're looking for nodules. We look at everything.
Right. Thank
Very,
you.
very good
Um,
information.
can we turn to prostate? So I've got a bunch of
Let's do
questions
it.
for that too.
We do have quite a
Um,
few of those.
yeah, we have a lot of the prostate questions. The first question I'd like to ask you, Dr. Stenoien, is so you've talked a lot about early detection. So how much does it actually improve outcomes, to find prostate cancer early? And can it prevent future screenings and better treatment?
You know, again, we don't have a lot of data because there has not in the past been significant screening. We know based upon diagnostic examinations, treatment of patients, that we are substantially improving survivability. We're improving the quality of life. We know that our diagnostic algorithms are effective, but this hasn't been expanded to the screening population. Screening prostate it's evolving, it's in process. And so as we do more and more numbers over the next, say, 5 years, we're going to start to get some strong data. How many patients had a clinically significant cancer? What sort of impact are we making upon life expectancy? What sort of impact are we making on quality of life? There's a lot of data that we know we're moving in the right direction. We know we're doing the right thing by selecting the right patients, by getting great imaging, by doing, you know, by doing analysis of the images in a consistent way. But we don't have that quantitative data yet. It's coming. It's all coming.
Right.
Right, right.
Dr.
Okay.
Stenoien, a question on PSA, and you had mentioned screening for PSA in how that's changed for screening purposes and potentially reducing mortality. We use that, I guess, as a means for tracking it over time. Is that correct? Is that how men generally use it, or physicians, where if it goes up from a 3 to a 4 to like an 8, that might warrant further evaluation?
No, I mean it's super useful because you can see trends, and
Hmm.
obviously when something's going up, it raises a red flag. At the same time, there's a large variability in PSA values. I mean, it depends on the volume of your prostate. We actually look at PSA density as opposed to total PSA in our patients when we're able to do that. We know that certain drugs can interfere with PSA values, will artificially lower those PSA values. Patients with inflammation of their prostate will have high PSA levels. So it's super helpful, but it's not a fixed, there's not a set level we can choose. We're going to look at trends. We're going to look at what's the maximum value, and is it going up or down over time. So yeah, helpful, but I think prostate has a lot to offer in terms of screening imaging because it's going to give us the anatomic data that's going to be supportive of how do we manage this patient.
So would it be accurate to say then, I guess a PSA would be a surrogate marker, or just, loosely associated with when to screen, but you can't just go based on PSA alone. Having a blood test when actually doing a prostate MRI would actually look for it. And you had mentioned medications though, and something that came up, in a discussion I had recently. Um, you know, medications such as, say, finasteride and dutasteride, historically men took it for enlarged prostate. But then, men oftentimes after the age of 40, we start to lose our hair a bit, and we might, take it, we might take it, for that. But we have all these online telehealth companies now that offer, say, topical medications for hair loss. A lot of times, historically, it was, Rogaine minoxidil, but now they have mixed in those same medications. So if you're taking those medications, could that potentially artificially lower your PSA so it's not as accurate to trend over time?
No, absolutely. They do lower the PSA and they do make that marker less accurate and less
Mm.
effective. Yeah.
So I guess prostate MRI would be the gold standard if you really wanted to look at what's going on, not just tracking an indirect surrogate marker over a period of years.
Well, if you have a normal PSA, is it possible you could still have a prostate cancer?
Absolutely. Absolutely. I mean, and there's no reason to give up on the old digital exam. I mean, it's still a good test.
Right.
I think digital exam, PSA, they're really good predictors of significant prostate disease. Screening MRI is just another tool in our armamentarium. I mean,
But a screening MRI will pick up a cancer in somebody who has a normal PSA. A PSA by itself is not the end all of screening tests, correct?
And at the same time, you can have a patient with an elevated PSA who has a normal screening MRI. And so
Mhm.
you use that as a factor. Does this patient really need to have a biopsy, or maybe come back in a year or two and recheck the PSA and recheck the prostate MRI?
Good point.
Mhm.
Right. So what would you say the advantages of having an MRI before biopsy are?
Well, when urologists do biopsies, they do random biopsies. They do a series of 12 biopsies. They hit all the quadrants. The benefit of having this imaging is that we can precisely show them where in the prostate this nodule is. So they'll do their 12 quadrant biopsies, but they'll also focus on the target lesion. I show you an image with two target lesions. They can fuse those images to their ultrasound images in real time and actually accurately get tissue samples where the MRI is positive.
Well,
Is there a
Um,
limit to how small the cancer can be? Have you seen them, the millimeters in size, or
I have friends who say they can biopsy a 4 millimeter cancer.
yeah, right.
wow.
I think the most accurate biopsies are MR guided. If you're talking about a 3 or 4 millimeter cancer,
Mhm, mhm.
you can see it, you can put the needle in, you confirm it's in the right place. I mean, once you get to have small lesions, I think it becomes a little bit more problematic. But yeah, they're really good. I mean, they get great results with our MRs.
Well, Dr. Stenoien, for the procedure for prostate MRI, people who might have claustrophobia, is it head first? Is it feet first? How long does it take? And from my own knowledge, I think things may have changed from when I initially trained. Do you still use an endorectal coil for this imaging?
Um, as as a as a person with no personal experience with the transrectal probe, but lots of friends who had it, nobody wants to have that transrectal probe. It's a stiff probe. They insert it into the rectum and they inflate a balloon. So about 35% of patients couldn't even complete the study. We're using surface coils. They're outside of the body. The image scan time is 10 minutes.
Wow.
Patient typically goes in foot first. I will say that if you're not super tall, part of your head is going to be under the scanner because of the length of the gantry. So there are still some issues with claustrophobia, but if you can scan a patient in 10 minutes,
Yeah.
those issues can be minimized, and we get very quick
Right.
scans.
Wow.
I have a question from an attendee. Someone who, let's say, has a full body MRI and there's a suspicious finding in the prostate. Would a dedicated prostate MRI provide better images?
Um, Absolutely yes, because you're going to get small field of view images. You're going to spend your time getting the optimal signal to noise ratio to get better resolution. You're going to probably have some additional sequences. And if you have a lesion, if you're evaluating a lesion, you're going to do a diagnostic study. You're going to get IV contrast. So absolutely, much more beneficial.
This is sort of a specific question regarding someone who's gone through radiation and Lupron shots for prostate cancer. They're just wondering if you know when their testosterone and sexual function might come back, if you have any sense of that.
That's a real individualized
Yeah.
question. And you need to talk to your urologist. We know that Lupron, long-term Lupron, is going to affect your sexual desire. It's going to affect your erectile dysfunction. And so the question is, when can you discontinue it? If you're cured, technically, you go through a period of time when you're on Lupron and then you go off. And once you go off, you should have some recovery, but it's going to be different in every patient.
Right. Yeah. Um, okay. And this is sort of a general question for all of you. It's regarding contrast agents and what those risks are. And patients who might have certain conditions who should avoid certain contrast agents. I know that comes up a lot.
Yeah, I'll take that. We are well aware of the contrast agents that we use them all day long in many, many patients. So we're well aware of the risks associated with the contrast agents, and we do what we can to mitigate. For MRI contrast versus CT contrast, they're completely different agents and they have different issues. But for the most part, the MRI agents, we've changed them all. The issues that we had maybe 10 years ago have resolved because now we have newer, more modern agents that have solved some of the issues that we have. So some things like gadolinium deposition, hopefully that's done, right? Because now we have agents that are better, that don't let that gadolinium dissociate, sort of. That's the medical term, but that's the issue. And for CT contrast agents, yeah, we've also relaxed a lot of our guidelines. The ACR, American College of Radiology, publishes a document every year and about contrast agents. And over time, they've kind of whittled away a lot of the myths that we've dealt with
Yeah.
for contrast agents. So things that we used to worry about, we no longer worry about because the truth is there wasn't that much data to support it.
Right.
So I think a lot of those issues have gone away. But the real issues we're screening for them. Before we give you a shot of contrast, we want to know the issues that you might face ahead of time. Does that make sense to you guys?
Absolutely correct. I mean,
Okay.
I think a lot has changed in the data regarding both contrast agents. And, what I deal with predominantly these days is CT contrast. And, the contraindications from when I started my career to today have completely changed.
Yeah.
It does not overly concern me about renal function and CT contrast. We still are very conservative and for certain high risk individuals, we will screen and check renal function, but it is not the same level of concern based on newer data.
Yeah. Yeah.
Mm. Um, okay. So let's talk about cardiac. Um, quick question. Let's see. Can plaque in the arteries be reversed?
Yes, not in every patient. I mean, there are two things about this. In most patients, historically, it did progress. A lot of the times, what would happen is you would check a cholesterol. Someone say, "Oh, your total cholesterol's a little high. Let's try a medication." It brings it down to the quote unquote normal range. You're down in the normal range. It's high fives all around. You're doing great. 10, 15 years later, you might have a cardiac event. Why? That wasn't enough for you. Things kept progressing, or your plaque did not stabilize. Never actually took a look. Um, when you actually take a look, you can determine if that medication was actually enough for you and whether or not your plaque is still progressing. Every single day, I see follow-up scans from people 3, 4, 5 years ago where we've either significantly slowed it down, we have stopped it in some patients, and in others even reversed it. Now, truthfully, when you have plaque reversal, oftentimes it's when you don't have these additional risk factors. They are people who might not have diabetes, or if they have diabetes, it's very well controlled. People who don't have hypertension or well controlled. The people that I've seen reverse it are overall very aggressive in their own lifestyle changes, and if needed, medical therapy. So it's not everyone, but you don't know how aggressive you need to be until you've actually taken a look. So I think that's really the value of imaging early.
Are there medications for plaque?
There are medications that help offset some of the risk, which then indirectly, affect plaque in that regard. So there's not a medication that says this is indications for plaque.
Mhm.
What happens is, let's say you have a high cholesterol levels. You can take medications which will bring them into a lower range. Whether or not the currently accepted normal range is enough for you really depends on the individual. Um,
Right.
if you look at normal ranges over the last 30 years, they keep trending down, 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 down based on newer data. So there are multiple medications that one can use. I would encourage people attending to discuss that with your doctor. In the last 10 years, we've had multiple new classes of medications that I've personally witnessed to be very, very effective at stabilizing and reversing plaque. So not everyone needs medications, but when you do, there are a lot of tools that you and your physician can discuss.
Mhm.
So I have
Um,
a question. So let's say you do a calcium score and you have calcium,
Mhm.
right? Where do you go from there? I mean, do you go on for a CTA of the heart, or do you just do statins? When do you go from a calcium score to a CTA?
That's a great question. And the first thing I want to make sure I mention is um, what to do with a calcium score, which is if it's anything other than zero, don't get another calcium score. So if you have a calcium score of, let's call it 50, and now your doctor put you on statins, do not get a calcium score again to follow that. It has no value. Reason being is taking medications like statins will increase your amount of calcified plaque. It's not that it's increasing the amount of plaque that is there, but it can take your non-calcified plaque and calcify it and stabilize it. You want it to do that, actually. So just because your calcium score went higher doesn't mean that's a bad thing. That could have actually been a good thing. So it's not adding value. The value in a calcium score is what they call is the power of zero. Anything other than zero, that means you have coronary artery disease and you don't follow it with another calcium score. So in those patients, the new dyslipidemia guidelines that came out 2 months ago, it answered that question about what to do with the calcium score in people other than zero. And their conclusion, based on that consensus, was calcium score greater than zero, initiate lipid lowering therapy. So you want to make sure that you are treating people who already have calcified plaque. Um, but at the same time, you don't know how aggressive to be. So if you have someone who has a calcium score greater than zero and they are of low to intermediate risk, not everyone needs to move on to a coronary CTA. With that said, the higher the amount of calcified plaque burden that is there, the more likely you're going to have a major adverse cardiac event, the higher risk you are. So there is not a consensus among any society about what to do with a calcium score, what to do with a coronary CTA data. Everyone has different opinions. You have imaging societies, you have dyslipidemia societies, you have cardiology, radiology. I hope in the coming years we'll have some additional guidance. But what I would suggest is talking anyone who has a calcium score, talk to your doctor. If you have calcified plaque, you are now higher risk. Um, how high risk depends on your individual profile. Um, Even if you had a calcium score of zero, if you were one of those higher risk groups that I had mentioned, HIV, diabetes, you might want to talk to your doctor about if there's a value for coronary CTA for you to get a better look at your coronary artery. So that's a great picture. And I hope when we do a follow-up webinar in the coming years, we'll have some real society guidelines that will be able to say, yes, based on this data, this is how you should manage it.
Just a quick follow-up on calcium score. 7 years ago, I had a calcium score of zero. I kind of never want to check again.
Go off on a high note. Here we go.
How often should we go back? Every 5 years, every 3 years? What are
So
your thoughts on that?
it's a great question, and it was answered a little bit in the dyslipidemia guidelines and some other societies recently, where the general consensus can range anywhere between 3 to 7 years. And so I'm giving that range to account for different opinions. But I think 5 years is a very reasonable recommendation. So you're a little overdue, Dr. Stenoien. We can image you early next week. We'll take care of you.
Sucks. Thank you.
Right, so we're coming up, we're actually a little over our hour, but I want to ask you a couple general questions for all of you, and then we can close it out. But one question is, why is it that certain demographic groups have higher rates of disease? I know a couple of you have mentioned that. Any thoughts on that?
So I'll talk briefly about coronary artery disease, and I hadn't mentioned the South Asian population.
Hmm.
And there are a lot of speculation about different ethnic groups and why. There are certain theories and there's ongoing research into this. But speaking about that particular group, there is a thought that there might be more more or a different type of fat around the coronary arteries that contributes to an inflammatory condition. Um, Sometimes, though, it could be certain environmental factors. It could be certain lifestyle. So it really does vary, and sometimes it's access to care for different groups. So it's very general, and it's a good discussion. And there's a lot of papers that go out based on that because you need to be aware of it if it's going to modify your treatment. I had
Yeah.
mentioned the South Asian population, and I have seen men in their early 30s with severe coronary artery disease, and no other risk factors that I could be had on paper. And we're not talking about isolated incidents, but many cases of that. So I started speaking to some leaders in the community and sharing data on it, but I hope we'll have new data in the coming years.
Yeah. And speaking of access to care, we did have a question from someone who works in public health regarding these very important screenings and, the fact that they're not free. So just wondering if any of you know of resources for, more vulnerable, lower income populations.
I do know that some grants have gone out for low dose cancer screening of the lungs. There are public grants in different places in the United States. It's not widespread,
Yeah.
um, but I think it's certainly a valid thing to pursue, especially with some of these managed care plans, and continue to educate and influence because it's definitely making an impact on
Yeah.
survivability. So yeah.
Definitely advocating for those things. So that's pretty much our time, but thank you, doctors, and thank everyone for joining us. Dr. Coords, if you have any last words.
Thank you, Stephanie. You did a wonderful job.
Oh,
And thank you, gentlemen.
Agreed.
Always good seeing you both, and hope to catch up again soon.
yes, and I just want to let everyone know if you want more information about any of these screenings, you can visit our website, radnet.com. And if you're interested in scheduling a cardiac, lung, or prostate screening, or if you want additional information, you can email our team at populationhealth@radnet.com and we will help you get scheduled. So, on behalf of our physicians and the entire RadNet team, thank you for spending part of your day with us.